Greetings from sunny South Africa to all the webinar participants. I am pleased to be presenting to you today wearing my Workplace Health Without Borders hat. My other affiliations are indicated in this opening slide, and these are the International Commission on Occupational Health, ICO, the University of Pretoria, and the South African Society of Occupational Medicine. The novel coronavirus has brought to wider consciousness inequalities in areas from healthcare to technology. These inequalities are felt along various lines, from ethnicity to income. Minority groups and people with disabilities face multiple barriers in access to essential services. The COVID-19 pandemic has thrown socioeconomic inequalities into sharp focus. From access to healthcare and green spaces to work and education, here are 7 areas of society where the coronavirus has shown up real disparities. Number 1. Health access outcomes. The bottom line is that inequality in access to health services persists. Issues are highlighted along the lines of gender, race, and residence status, with women and migrants facing particular difficulties. The pandemic has highlighted the impact of socioeconomic conditions on health. Minority ethnic groups have been disproportionately affected by COVID-19, particularly Black and Asian groups. These disparities within countries are over and above the inequalities that exist between countries. And here are 2 examples. 95% of TB deaths occur in the developing world, and global life expectancy can vary by as much as 34 years. 87% of premature deaths due to non-communicable diseases occur in low and middle-income countries. Most COVID-19 fatalities will be amongst those with underlying illnesses such as high blood pressure, diabetes, and heart or respiratory conditions. The risks of mental ill health will be exacerbated by isolation, fear, and insecurity across all groups. Controlling the spread of the disease is important now. Next, we will need to address the high and rising levels of chronic diseases and also reduce the pressure on care services. People in poorer socioeconomic circumstances can also be more exposed to infection. They may be unable to self-isolate, and COVID-19 is experienced more severely in disadvantaged neighborhoods. They are more likely to experience unemployment and financial insecurities and are more vulnerable to labor market fluctuations. Number 2, access to green spaces. We know that access to green spaces and nature improve both our physical and mental health. But access to these spaces is unequal, with more affluent areas having access to a higher percentage of public green spaces. Here are 2 examples. In South Africa, so-called white neighborhoods are 700 meters closer to public parks than areas with predominantly black residents. And in Germany, inequalities in access to urban green spaces have been highlighted in relation to income, age, education, and numbers of children in households. Number 3, the digital divide. Millions of workers and school children have been sent home, forced to work remotely by lockdowns and social distancing rules. This has highlighted gaps in access to technology and the internet. For example, around 50% of people in India don't have access to the internet, and in many African countries, the percentage is much higher. COVID-19 has exacerbated the disparities within countries, where differences persist along income, age, race, and urban or rural lines. Number 4, jobs in a virtual world. The share of people who work from home is closely linked to internet penetration. Those with poor internet connections at home will find it hard to cope in a new virtual video conferencing world, even in countries with high levels of internet access. Higher educated and higher skilled workers are more likely to work in occupations where remote working is possible. In contrast, lower skilled workers are more prone to job losses or reduction in hours. I found this quote by Nicholas Bloom, a Stanford economist, to be very apt. He said, "Those unable to work from home are being left behind. They face bleak prospects if their skills and work experience erode during an extended shutdown and beyond. Number 5. Accessibility and disability. In the UK, 2/3 of people with visual impairments feel they've become less independent since the start of lockdown. And also in the UK, more than 2/3 of COVID-19 deaths have been people with a disability. Those with disabilities face higher risk during the pandemic, including an increased risk of developing severe disease. Social distancing can also be hard for these groups. Disruptions to essential services, including healthcare, also put people at risk. A WHO mental health survey showed that a high proportion of people had received no treatment in the previous year in both developed and low and middle income countries. Across the European Union, less than 1 person out of 2 with basic activity difficulties is employed. Number 6. Vulnerable populations, racial and ethnic minorities. Some of the many inequities in social determinants of health that put racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19 include the following: discrimination and racism in terms of healthcare, housing, educational, criminal justice, and finance; healthcare access and utilization, for example, no medical insurance; communication and language barriers and cultural differences; and occupation, as minorities are disproportionately represented in certain essential work settings. Other inequities include educational, income, and wealth gaps, such as limited job options, lower paying or less stable jobs, less flexibility to leave jobs; housing, crowded conditions make it more challenging to follow prevention strategies; and unintentional harm from community strategies to prevent the spread of COVID-19 leads to lost wages, reduced access to services, and increased stress. And number 7, COVID-19 and gender inequities. COVID-19 has hurt women and girls in many ways. Women have been pushed back into the home. Healthcare workers and caregivers, who are mostly women, are jeopardizing their own health caring for others. Women are 70% of the global health workforce and the majority of social workers and caregivers. Women deliver 70% of global caregiving hours. And women subsidize health globally. 50% of the care they provide, which includes work as vaccinators and community health workers, is unpaid. Immigrant women are another group who tend not to have access to health care. Reports of gender-based violence have risen due to the isolation from lockdowns and tensions in households due to financial and economic stresses. For women and girls who are further marginalized, like women with disabilities, refugees, and indigenous groups, the risks of experiencing gender-based violence is even greater. The COVID-19 crisis is also threatening sexual and reproductive health and rights. There are probably very few workers worldwide who can say that they have not been affected by COVID-19. At international, regional, and local levels, and across all sectors, organizations including ICO have mobilized their resources and skills to develop and share all they can about COVID-19 for the benefit of their workers, their families, and their communities. These include policies, legislation updates, technical guidance documents, training materials, official statements, risk assessment tools, standard operating procedures, action frameworks, and return to work guidelines, among many others. Many organizations, including Workplace Health Without Borders, have dedicated COVID-19 resources on their websites and have shared learnings through countless virtual information sessions like webinars, symposia, conferences, and workshops. Here now are some key take-home messages of what we have learned. COVID-19 poses a threat to both public health and occupational health. COVID-19 is the first new occupational disease to be described in this decade. Working in healthcare settings can be hazardous to health. However, there are diverse occupational groups that are recognized to be at risk. Around 14% of COVID-19 cases reported to WHO are among health workers. In some countries, the proportion can be as high as 35%. Healthcare facilities have been and are being overwhelmed in many countries. The shortcomings in the availability and/or standards of personal protective equipment have left large numbers of healthcare and other workers without adequate protection. We continue with the lessons. General principles of prevention and control are effective in containing the disease. Traditional occupational hygiene measures, which follow the hierarchy of controls, must be comprehensive and prescriptive to prevent viral recurrence. Hand hygiene plus social distancing plus scientifically sound information are the best strategies currently to combat this epidemic. Infections can be prevented by early identification, isolation, personal hygiene, and immunization when available. Importantly, if poorly controlled, emerging infections have the potential to cause epidemics with a high socioeconomic impact and will continue to be real threats to the world. We need to remain vigilant to be ready and able to respond effectively. Lessons everywhere. The impact of COVID-19 extends far beyond infection and health outcomes. A major concern of many workers is the fear of job losses or loss of income. The work and family challenges brought on by the pandemic are unprecedented and severe. The COVID-19 crisis, lockdown, and economic recessions will exacerbate pre-existing health inequalities. Lower socioeconomic workers have less access to protective equipment, fewer options to work from home, and a higher risk of losing their job. Importantly, the pandemic has highlighted the critical need for very close trans and multidisciplinary collaboration between various professionals to inform better decision-making by organizations. In summary, it can be said that COVID-19 is a syndemic pandemic. It interacts with and exacerbates existing inequalities in chronic diseases and the social determinants of health. The prevalence and severity of the COVID-19 pandemic is magnified because of pre-existing epidemics of chronic disease, which are themselves associated with social determinants of health, such as housing and work conditions and access to quality health care. Hence, COVID-19 is experienced unequally, with higher rates of infection and mortality among the most disadvantaged communities. It is certainly not a socially neutral disease. Vaccines to prevent COVID-19 are perhaps the best hope for ending the pandemic. However, wearing masks, hand washing, and physical distancing remain necessary until a sufficient number of people are immune. Many myths abound, but here are some fast facts on the vaccines. As COVID-19 vaccines become available, the world must have the infrastructure, supply chains, and distribution plans in place to introduce the vaccines on an unprecedented scale and at high speed. None of the vaccines being developed use the live virus. The Pfizer and Moderna vaccines use messenger RNA. Both vaccines have been scientifically proven to be very safe. The vaccines were developed quickly because of the worldwide effort. There is nothing in either vaccine that could affect anyone's genetic makeup. And there are certainly no tracking chips in any of the vaccines. Immunity from the vaccines is far safer than natural immunity. Viruses constantly change through mutation, and new variants of a virus are expected to occur over time. Multiple variants of the coronavirus have emerged more recently and are circulating globally. Examples are the distinct variants identified in the UK, Brazil, and South Africa. These variants seem to spread more easily and quickly than other variants, which may lead to more cases of COVID-19 globally. The AstraZeneca vaccine has now been shown to provide only minimal protection against the new variant that is widespread in South Africa, and this South African variant has since been found in at least 30 countries. Hence, many countries will need to adjust their vaccine rollout plans, and South Africa is at the forefront of this challenge. It's a race against time and a severe blow in the fight to eradicate COVID-19. Vaccine rollouts will require continuous calibration to test their efficacy against the emerging variants. Hence, South Africa has halted the rollout of the AstraZeneca vaccine and will investigate the use of the Johnson & Johnson, Pfizer and Moderna vaccines against the new variant. However, only the efficacy of the Johnson & Johnson vaccine has been studied so far in South Africa during the new variant's emergence. In the last two slides, I end off my presentation by mentioning a different sort of inequity brought on by the COVID-19 pandemic in South Africa. And this is the impact of fraud, bribery and corruption that have touched all aspects of the measures to manage and contain the pandemic. This inequity has impacted the poorest sectors of society the most. There is widespread corruption involving relief funds meant to deal with the COVID-19 pandemic. Massive corruption surrounding the purchasing and supply of personal protective equipment puts the workers at risk when taking care of patients. The graft involves overpricing, substandard products and services, irregular contracts, and giving tenders to those connected to the government and the ruling party. Numerous companies who receive purchase orders from the Department of Health are under investigation. Many high-ranking government officials are under investigation. Corruption is rampant at all provincial treasuries, health departments, and within municipalities. It is shameful and disgraceful that during an ongoing national COVID-19 lockdown that has lasted almost a year, individuals are stealing at a time when the country faces malnutrition, retrenchments and business closures, and communities are unable to access health care and other services. Thank you for your attention.